All right, welcome back, everybody. We are on to lecture 4. So we've had an intro lecture and then kinetics, and then an introductory lecture to just basic synovial joints in the body. So now we'll start jumping into more specific sections of the body. And again, I think this is where probably a lot of you are most excited and kind of hoping to look at more specific regions of the body, kind of get out of the introductory material and look at how you could implement some of this material into your practice with patients and clients. So let's jump in. So we're going to start with spine, and then we will go into upper quarter. So we'll do shoulder, elbow, wrist, and hand, and then we'll do lower quarter, and where we'll look at hip, knee, ankle, and foot. So that's kind of the plan from here. And then maybe at the end of the lectures, we'll come back and look at bone and muscle and things like that. I wanted to be able to jump into the joints sooner than later because I know a lot of people, this is usually what people are most interested in, so I wanted to get to it more quickly. So, all right, so we'll look at the 3 sections of the spine today, and let's jump in. So we're going to start with just some basic kind of overview stuff, functions of the spine. One of the things we think of right off the bat, the spine helps protect our nervous system and especially the spinal cord. You can think about your spinal cord, you imagine it running down through each section of the spine, through this area, this hole in the vertebrae called the central foramen, and that bony housing helps to protect the spinal cord. So that's obviously a major function. The spine is interesting in that, we usually see with joints, either they're very good at mobility or they're very good at stability. The spine is really interesting in that its architecture, its structure allows it to have both things. So, and we'll look at the mobility characteristics of each part of the spine, the low back, the lumbar spine, the thoracic spine, and the cervical spine, and they each contribute a little differently to mobility, overall mobility. We'll see that some areas are better at flexion extension, some are better at rotation, things like that. But overall, the spine is really quite mobile. We can move in all 3 planes of motion and through a pretty large range of motion, but at the same time, the spine is really stable because it's got to protect the spinal cord. It needs to be an attachment site for lots of ligaments and muscles and tendons, so it's really a pretty neat structure. Again, like I've said before, this is really one of my favorite areas. I really enjoy treating spinal pain and just thinking about the complexity of the spine. We also think about the spine as being a structure that helps to absorb force and transmit force. You might think of the normal curves of the spine. Those curves are thought to help us absorb shock and absorb force. There's even a test we do sometimes where we'll kind of push down on somebody's shoulders when they're standing, and we'll look at how much their spine gives as a test to sort of look at, is the spine a little more hypermobile or hypo? You might imagine people, if you've ever looked at people's spines from the back, some people have very straight, kind of vertically oriented spines with very little curves, and those individuals are sometimes thought to maybe their spine, the structure of it isn't as great at absorbing shock because everything's sort of stacked in a straight line versus having those curves. And then on the other side of the spectrum, you see people who have really exaggerated curves in their spine, and so you can see both sides of the spectrum. Neither one's really bad or good. It's just we're all built differently and we adapt to those things, but you can see some of those differences, and those can play into how we absorb and transmit forces. And like I said before, spine is hugely important, especially the back side of the spine, the posterior side of the spine, for tendon and ligament attachments. If you've had anatomy at all, and you've done the back muscle. Sometimes anatomy classes kind of save the back muscle for later. So you might have to be in a more advanced anatomy class to learn that material, but tons of muscles and ligaments attached to especially the back side of the spine, but we'll also see some on the front too. So just some basic functional overview type material. So, and again, we'll look just a organizational breakdown of the spine. There's 24 movable vertebrae, and those are going to be these first 3 sections: our neck or cervical spine, the mid-back, the 12 vertebrae of the thoracic spine, and then the 5 vertebrae of the lumbar spine. Those make up our 24 movable vertebrae, and you can see they're broken down here by how many vertebrae in each section. So we've got 7 vertebrae in the neck, 12 vertebrae in the thoracic region. This is also where our ribs connect. And then 5 in the lumbar spine, the low back. And then we have 8 to 10 fused vertebrae. So the sacral region here in green, there's 5 fused vertebrae. And then the coccyx can range, there's some variability there, from 3 to 5 fused vertebrae. So again, we're not going to really think about moving anything down in that region. It's not really a focus. When you are a movement, fitness, or rehab practitioner, we'll really focus on these top 24 movable vertebrae throughout this lecture. So, all right. There's something important to know. There's something referred to as the motion segment, which this is the functional unit of the spine. So when we think about breaking the spine down into a smaller element and looking at its functional characteristics, we would think about the motion segment. It's basically what this picture shows. It's 2 vertebrae and the disc between them. So that right there is considered the motion segment. So again, just 2 adjacent vertebrae and the soft tissues between them, which really we're thinking about the intervertebral disc and the 2 vertebrae. And then you'll have a nerve root here that comes out, one on each side, a left one and a right one. Those are branching off the spinal cord. We'll get more into this area when we start talking about disc herniations and spinal stenosis. But again, this is considered the functional unit of the spine, the motion segment. So that can be helpful to know. That often comes up in different types of courses and things if you're going on to graduate school. Spinal curves, these are broken down into 2 categories. So we have the primary curves, which are the thoracic and sacral curves, and those are the 2 that form this kyphosis, sort of an outward curve. So if you're looking at the back side of someone's body, they would be convex, so the curve is pointing out. So the thoracic spine, we can all think about that. The mid-back of most people is kind of rounded. And then also the sacral curve is kyphotic. It has a rounded it pushes out, has a convexity on the back side. You can kind of think about the curves of the glutes and the butt, kind of that outward curve. And then in between those 2 are the secondary curves, our cervical spine and our lumbar spine, which both have these inward concave type curves that we're looking from the backside, and those are referred to as lordotic curves. So we see that again in the neck and the low back. Those develop as we start growing, and are thought to be related to assuming upright positions, and in crawling we see both of these start to develop, especially the cervical lordotic curve when babies start crawling and they're using their neck muscles to lift their head and look forward as they crawl, so that helps to form that lordosis in the neck. And then the lumbar lordosis, as we start standing and weight stacks on the spine, it creates that inward curve. So again, primary and secondary curves. And the curves, like I was mentioning in the earlier slide, help us to absorb shock. You can imagine, especially the lumbar lordosis, that kind of inward curve. If you imagine kind of standing, jumping, things like that, that curve can kind of give a little bit and absorb some shock, rather than your spine just being, if all the vertebrae were stacked directly on top of each other, it'd just be this real stiff sort of structure that wouldn't be as great in terms of absorbing shock. So those curves definitely help in that area. So, and we'll sometimes refer to people when we do a posture analysis. Some people, like I said before, we'll see that have extra sort of curves, and we think of that as more of a dynamic spine. And then if we see someone that has a really straight spine, we refer to that as more of a static spine. And so those are things we just notice and note in our postural assessment. Okay, so jumping into the lumbar spine, we're going to start in the low back. There are 5 vertebrae, as I mentioned before. These are named from superior to inferior. So L1 is the one that is closest to your head, so it's up highest. And then as we go down towards the tailbone, we count down. So L1, 2, 3, 4, 5, those 5 vertebrae. And then connecting those vertebrae are facet joints, or more technically they're referred to as the zygapophyseal joints, or Z joints, but I'll mostly just refer to them as facet joints, and I'll show a picture of this here in a second. But if you look at 2 vertebrae stacked on each other, the vertebrae are going to have a superior facet, and the vertebrae above is going to have an inferior facet, and those hook on each other, and those 2 bones slide on each other, and that creates your facet joints. They're plain synovial joints. Plain joints just mean they kind of slide on each other. They're synovial joints, so they're just like our other synovial joints. They have a joint capsule, synovial fluid, all those things we talked about before, and they're small. I always tell people when I'm working on them in the clinic that they're about the size of the knuckles on your fingers. And so if you think about if you've ever had your spine manipulated and it pops, it's the same as your finger joints. That's what's popping, are those little facet joints in between the vertebrae. So nothing really to freak out about it, just a little joint that pops just like your fingers do. So those are the facet joints, and we won't see those just in the lumbar spine. We're going to see them through the whole spine. Thoracic region, cervical region. These facet joints are what allow us to move in all three planes of motion, so they're present throughout the whole spine. Here's a nice little image. This is showing a facet injection, which is sometimes done to people who are thought to have pain that's originating from a facet joint. So you can see here, we have two vertebrae, right? Here's a motion segment. This superior vertebrae is going to have a facet that projects downwardly, so that's an inferior facet, and then this lower vertebrae is going to have a superior facet that projects upward. Those two will hook together and slide on each other to create a facet joint, just like, again, each vertebrae has a facet that projects upwardly and one that projects downwardly, so there's another facet joint right down here. So this is how each vertebrae is connecting to the next one through these facet joints, and obviously there's one on the other side of the spine that we can't see. So if this is the person's right side, these are their right facet joints, and then there would be left facet joints on the other side. And we'll talk about their mechanics as we go through movement. Our facet joints are said to open and close, so we'll talk about when are they opening, when are they closing, depending on movement. This here you can show that you see in the picture, she's leaning forward into flexion. When you move forward into flexion, it opens the facet joints. They open up a little bit wider on both sides, so it makes it easier for an injection to enter the joint space and help there. So, all right, and then also structurally, just a few of the ligaments. There's a few more out there. I'm just talking about some of the major players here, but these are helpful to know in terms of restricting movement. So this first one here is the anterior longitudinal ligament, which anterior means it's on the front side of the body, right? So this is on the front side of the spine, where the vertebral bodies are, closer to your organs and your guts, kind of on the inside there. And since it's on the front side, it's going to get tight when you extend your spine. So when you arch backwards, that ligament will become tight and so it restricts extension. It sort of helps your spine from extending too far and becoming injured. The posterior longitudinal ligament kind of does this exact opposite. It runs on the posterior surface from the sacrum all the way up to C2, the second highest vertebrae, and it restricts flexion. It's on the back side of the spine, so when you bend forward, it becomes tight, so it stops you and kind of helps guide that motion and protect things from, shifting too far. The supraspinous ligament is another one on the back side of the spine. This one runs over the spinous processes of the spine. So if you imagine somebody bending forward and you're looking at them from the back, you can see their spinous processes kind of poke out. If they're skinny, you can see them poke out on the back side of their spine. That ligament's right on top, so it's very superficial. You can actually kind of touch in between. You can palpate the supraspinous ligament. Sometimes we do this if we think maybe it is a source of pain. But because it's on the back side of the spine, it will also restrict flexion, like the posterior longitudinal ligament. So those are mainly controlling movement in the sagittal plane, that forward and back plane. Okay, so those are kind of the big three we're going to talk about, and you can see them here. So on the front side here are the vertebral bodies, right, one on top of another, and the disc in between. Here's the anterior longitudinal ligament, this really broad ligament that runs on the front side of the spine. So you can imagine if you arched your back, that would get tight. Posterior longitudinal ligament is on the back side of the vertebrae. It runs in the central foramen here. The spinal cord would be right here too. So the spinal cord would be behind this ligament. So it's a more narrow ligament than the anterior longitudinal, but again, that one's going to restrict flexion. Supraspinous ligament is way on the back here. It's on the way back side of the spine, connecting these spinous processes on the back side. And, again, there's some other ones. There's this ligamentum flavum. There's an intertransverse ligament that goes between the transverse processes. And then here also it shows the capsule. You can see right here is a facet joint that's just open and exposed. Here is what it actually looks like in the body, where there's a ligamentous, a connective tissue joint capsule, again, just like our other synovial joints, that holds in all the joint fluid. So again, these are the little joints that pop when you twist your spine, Again, about the size of your knuckles in your hand, something like that. Okay, so just a little image there to see some of the ligaments. And also in terms of structure, these things will be in all the regions of the spine, but we're kind of introducing them here for the first time. But nerve roots, again, there's a right and a left nerve root at each level, and they come out a small hole on the side of the spine called the intervertebral foramen. Sometimes when people are older, they'll have arthritis in this foramen, and that can cause something called lateral spinal stenosis. So if you hear of somebody having numbness and tingling in an arm or leg and they're older, it could be related to arthritis in this area. These nerve roots are responsible for both motor and sensory function, so they are involved in sensation in our arms and legs. If we're in the low back, they would be sensation for our legs, and for motor responses, so they're really important. This is where if a nerve root is really compromised, say somebody has a really large disc herniation and it's mechanically impinging on the nerve root, they might have sensory disturbances like numbness, tingling, they may have pain, and if it gets really bad, they can have motor disturbances where they start to develop weakness, they can't move an area. We see this a lot in the lower body. We see it with the ankle dorsiflexors, where if it gets really bad, it can paralyze their ankle dorsiflexors and they end up having drop foot, where their foot kind of falls and they can't lift it. It might catch on things. So those are really bad scenarios. We try to get people to the appropriate care way before so those kind of things don't happen. So like it says here, the status of the intervertebral disc and the facet joint, they have a direct impact on the health of the nerve. So disc herniations, especially large ones, can impact the nerve root, obviously. And like I said, the facet joint, if there's arthritis in the facet joint, that could narrow the intervertebral foramen and lead to stenosis. So really important to think about these areas and pay attention to nerve root signs in clients or patients, because although our peripheral nerves, the nerve roots that are part of the peripheral nervous system, have the ability to regenerate somewhat, if they become too compromised, they don't regenerate. And I've seen cases in the past where people who weren't trained in this let their clients, they didn't send them for medical checks, and they ended up having permanent paralysis in a muscle because the person just wasn't really paying attention to the symptoms and wasn't referring them on for medical screening and care. So if you see something like this where people have got numbness, tingling, and especially starting to develop weakness, it's really important to send them to their doctor. Here's an image looking at the nerve roots coming out. If you look at the spinal cord here, so here's the front side of the spine, these are the vertebral bodies. Here's the back side of the spine, these are the little bony projections, the spinous process, and here's the transverse process on each side. The spinal cord is there in this center area, and within the spinal cord, this is the nerve root. The nerve root has a ventral portion, this ventral rootlet, and a dorsal rootlet. What's key about these is that the ventral side carries the motor, so it carries the motor information. So if you're thinking about moving a muscle, activating a muscle, that is associated with the ventral rootlet. And then the dorsal rootlet is where sensory information comes in. So if somebody touches you on your leg, that information will be carried through the dorsal, into the dorsal side of the spinal cord. Information coming down from the brain to move a muscle would go through the ventral rootlet and then out through they end up both merging into the nerve root and going out and forming our big peripheral nerves. This is another little structure you can see here. This is called these little bulbs are called the dorsal root ganglion, and that's part of the sensory information. Sometimes people refer to it as sort of a little mini brain. So it helps with processing of sensory information before it goes into the spinal cord. So again, so we have ventral is motor, dorsal is sensory, and then this is the nerve root. There's one on both sides. And these nerve roots will come out and they will join together to form big nerves. Like we would have a bunch of nerve roots come together to form something like the sciatic nerve. So our big nerves that we think about are made up of a bunch of these, sometimes, it's 2 to 5 usually, nerve roots coming together. So, all right. Musculature in the lumbar spine, this is just broken down by categories of movement. If we think about our lumbar flexors, those are going to be our abdominals, so muscles like rectus abdominis. Our obliques can help with this, right? All those abdominal muscles. Psoas is also can be a flexor. Extensors are the big erector spinae on the back side of the spine. So we have iliocostalis lumborum, and they have this lumborum name after them. The name will change as they get up into other regions of the spine because many of these muscles run the whole length of the spine. So we'll put a little name, we'll use a naming system to tell what region. So for instance, iliocostalis would be lumborum here, and then it'd be iliocostalis thoracis in the thoracic spine, and then cervicis in the neck. So we'll differentiate that way. Longissimus is an important muscle. Multifidus is a huge one. I just did a post recently on multifidus. It's one that we see atrophies, and it's one where when people have back pain, low back pain on just one side, we see changes to the multifidus. So it's a muscle we work on training in people with low back pain. Rotators and extensors, so muscles that contribute to rotation. Multifidus, a lot of these muscles on the back side of the spine, if you squeeze them, if they contract just on one side, they will create rotation. The same with side bending or lateral flexion. If you take a muscle like iliocostalis lumborum, which is traditionally considered an extensor, if you have the right and left iliocostalis muscle contract, it will create spinal extension. If it only contracts on the right side, that will create side bend or lateral flexion. Quadratus lumborum is similar. This is one that we see is thought to be involved with many cases of low back pain, but it's also an important lateral flexor. So we can train this muscle with things like side planks and farmer carries and things like that. So just kind of a general breakdown by muscle action. Osteokinematics, so these are looking at movements in the spine, sort of larger movements. Remember we had osteokinematics, which are bone-on-bone movements. These are all the names we're all mostly familiar with. Flexion, extension. The interesting thing here is that I wanted to include where the most of this movement comes from. So if we look in the low back is really good at flexion and extension. And the motion where that motion occurs the most are the lower segments, L3-4, L4-5. And not too surprisingly, those lower segments are also where the low back tends to have the most wear and tear and disc herniations and injuries and things. So, if an area moves a lot, it's probably more likely to show some degenerative changes earlier than segments that don't move as much. Side bending or lateral flexion is greatest at the thoracolumbar junction, which is where the thoracic spine meets the lumbar spine, so up at T12 and L1. There's quite a bit of side bend that goes on there, and then again down at these lower segments. So the lower lumbar spine, there's a lot of movement that goes on there, so it's an area that we pay a lot of attention to. A lot of people with low back pain have symptoms down in these lower segments. Rotation in the lumbar spine is present, and it's similar throughout the whole region. It's not going to be as much. We get more rotation from our neck and from our thoracic spine, but there is some rotation down the lumbar spine. And I think I've got a graph here. Yeah, so this is a really useful one. You might want to save this for later. But this shows different movements. So down here we got flexion, extension, side bend, lateral flexion, and then rotation. And it shows it, of course, as it relates to each part of the spine. So for instance, in the low back, down here L1 through 5, we can see there's a lot of flexion extension, especially down here in the lower segments. And then if we look at side bending, pretty similar throughout, but again, maybe a little more up here at the thoracolumbar junction, a little more in some of these lower segments, but not a ton. Rotation, not much rotation in the low back, except for those very bottom, maybe L5S1, excuse me, that lowest segment. Rotation, though, on the other hand, we see more of it in the thoracic spine, and a ton up here in this joint. This joint's really interesting. It's the joint between our C1 vertebrae and C2, that's that pivot joint. And if you remember, I talked about in the joint lecture. That pivot joint, here's 0 to 20 degrees. This one joint right here gives about 45 degrees of rotation, which our neck in total gets 80 degrees of rotation. So this one joint gives us over half of our neck rotation. Okay, and then side bending, you can kind of see pretty even throughout the lumbar and thoracic spine, and then we get a little more up here in the neck. The thoracic spine doesn't have a ton of flexion extension. We see a lot more in the lumbar spine and then again in the neck. Our neck can move through a wide range of motion in terms of that forward and back flexion extension. So I think this is just a really useful chart to come back to kind of summarize the movement range of motion available in the spine. From an arthrokinematic standpoint, sorry, this is a lot on a slide to hit you at one time. Luckily in the spine, this stuff is not too complex. You just need to think about, are the facet joints opening or are they closing? So I said earlier, if we move into flexion, we bend forward to touch our toes. Our facet joints slide up on each other and open. So they kind of come apart, there's less contact, they open, and the hole where the nerve root comes out also opens. So that hole becomes wider, the diameter of it increases because the facet joints are sliding apart and opening. On the opposite side, if we go into extension, we arch our back, the facet joints slide down. They slide down on each other, and the intervertebral foramen closes. So we have less room for the nerve roots, and you'll hear this in people who have radicular pain, where the pain's coming from a nerve root. If they, especially if you think about the neck, if they extend their neck, a lot of times it'll call it shooting pain down into their arm, and that's thought to be associated with this intervertebral foramen closing, and it's almost like it's kind of choking the nerve root a little bit. So that's something you'll hear in people who have really sensitive nerve roots. Now, if we look at side bend and rotation, so what you're going to imagine, if I side bend one direction, say I side bend right, what's going to happen is the facet joints on the right-hand side are going to close, and the facet joints on the left-hand side are going to open. So we get the opposite thing on each side. So right side bend, I get closing on the right, opening on the left. If I then, for instance, think about rotating to the left and looking behind me, I'm going to get the opposite. I'll get closing on the left and opening on the right. So that's how you think about side bend and rotation. You just think about one side of the spine, the facet joints are closing, and on the other side, the facet joints are opening. So that's how you want to think about those two. So those are arthrokinematics. They're those smaller accessory motions that happen with the larger osteokinematic bone-on-bone movements. So hopefully that makes sense to you. Here's an image again of that facet joint motion. So here is flexion, bending forward on the left. The facet joint, so if you imagine if I bend forward, this superior vertebrae is going to tip forward, and that means that facet goes up. So these two come apart from each other, and this hole gets bigger. So the nerve roots are coming off that hole. So now there's more room for the nerve roots. And on the opposite side, if we have extension, the facet joints are closed. The top one is sliding down on the bottom one, so that's closing, and the intervertebral foramen becomes smaller. So again, people who have spinal stenosis usually like flexion and not as much extension. So older individuals who have spinal stenosis, one of the characteristic signs for them is that when they go to the grocery store, they might like to lean on their shopping cart, because if they lean forward on the shopping cart, it opens this intervertebral foramen, and they have less pain. Say they have a lumbar nerve root pain, it will help when they lean forward, it will help ease some of that pain into their legs. Or they might say that it hurts when they walk, but not when they ride a bike. So when they sit on a bike, it also opens up the joints here, so that feels better. Whereas when you're standing upright and walking, that puts you in more extension and closes the foramen, and so they might experience pain. So just one example with spinal stenosis. Not the same for everybody, but for some people you'll see those patterns. Okay, and here's a disc herniation. We have a sagittal view MRI here, where you can see changes in the disc. And you know, I always talk about this on my account. It's really important to know that having a disc herniation doesn't necessarily mean you'll have pain, but they are sometimes associated with pain. And you know, and again, and disc herniations can sometimes heal on their own. So you know, this is just, they're things to look at and to kind of work into the whole picture. Not necessarily, you don't want to just freak out about them if you see something like this. A lot of healthy people have disc herniations and have no problems, but a disc herniation usually will protrude posteriorly towards the spinal cord and the nerve roots, which we can't see here. But you know, one like this, if it were a really large disc herniation and actually touched the spinal cord, then people will have nerve pain usually in both sides of their body, to both legs or both arms or all four extremities. Most of the time that's not the case. Usually if people have a disc herniation, it just affects the nerve root. The disc will go backwards into one side, so it'll push on a nerve, or it'll irritate a nerve root. and so they'll have nerve symptoms in just one arm or just one leg. That's most typically what you see. Like somebody will have sciatica just on one side, and so you work on moving, and again, a lot of times discs can heal. They can reabsorb and pull back in if you give them enough time, and you work with the right movements and try not to make it worse and aggravate the area. So a pathology that comes up in the low back and again in the neck, they kind of follow the same thought pattern. And then spondylolisthesis is a condition where there's a fracture in the backside of the vertebrae, and the vertebral body shifts anteriorly. So if you look at the front side of this person's spine, this is a side view x-ray, you can see that these vertebral bodies are lined up with each other, but then this one shifts forward. So you really can see it compared to this bottom level. And these are graded based on how much they shift forward. So they'll get a grade 1, 2, 3, or 4, depending on how they shift. And you see this in dancers and gymnasts, people who do repeated spinal extension. You see that more commonly in those athletes in the low back. So, and again, it's one that some people have and they just live with it and it doesn't really bother them. They can do rehab and things and they get better. Some people have really bad ones, they don't get better, and they're more appropriate for surgery. But most of the time you see people who can be managed with just rehabilitation techniques, exercises, and things. So, okay, so and then spinal stenosis. This spinal stenosis just means a narrowing of a hole, basically. So one type of spinal stenosis, so this is supposed to be a normal picture. So here's the spinal cord, and then you have nerve roots coming out each side. So one type of stenosis is called central stenosis, where maybe there's a disc injury, so disc herniations can narrow this hole. Sometimes the ligaments can hypertrophy and kind of build up as people get older. There can be arthritis in the joint. If those things close down this central hole, it's called central stenosis, and it can interfere with the spinal cord. Also out here on either the right or left on the sides, you can get stenosis just on the side where the nerve root comes out, and that's called lateral stenosis. And again, it just means a narrowing of the hole. And sometimes it bothers people, sometimes it doesn't. And if it's, so we just basically look at the person's symptoms. You might have an x-ray or an MRI or something, and you work on trying to manage this by giving the nervous tissue some extra space. And maybe that's helping them with flexion exercises or things like that that open the area up. So spinal stenosis, again, just a narrowing of a hole, and it can be central around the spinal cord, or it can be lateral out here where the nerve roots come out. Okay, I know I'm going kind of quick here. I don't want to make the lecture too long, so I hope you're hanging with me. Thoracic spine is working our way up. The next 12 vertebrae where our ribs are going to connect. We're going to see the ribs come in now. So we've got 12 vertebrae in the thoracic spine and 12 ribs. And the ribs are broken down into categories based on how their anatomical attachments. So the ribs 1 through 7 are considered our true ribs because they attach directly to the sternum on the front side of your body. They have direct attachments into the sternum. Ribs 8 through 10, just below that, are considered false ribs. They have an indirect attachment to the sternum on the front side. You'll see, if you imagine the front side of the rib cage, you'd see this big piece of cartilage. Those lower ribs attach into that cartilage and then into the sternum. And then the last two are our floating ribs, and most people have heard of those. Those only attach to the spine. They don't attach to the sternum. So they kind of poke out on the side. They're our bottom two ribs, and they only attach to the back side of the spine. So all of our ribs attach to the spine, and then the top 10 also attach on the front to the sternum. The thoracic spine has all the same facet joints, just like the low back, and then we have some other joints. One on the anterior side is one that has very little motion. It's the manubriosternal joint. It's an amphiarthrodial joint. If you remember, that category is one of the ones that's slightly movable, just a tiny little bit of movement. And the same with the xiphisternal joint down at the bottom of the sternum where it articulates. There's a little process called the xiphoid process. We're not going to do much with these. They move a little bit with breathing and things like that, but not things you can really address as a movement practitioner. So they're not going to be areas you're going to do a ton with. So just know they're there. Posteriorly, though, we have these other joints where the ribs hook into the spine. So costo means rib, And so we have a joint where the rib hooks to the vertebral body, so it's called the costovertebral joint. And then there are joints called the costotransverse joints where the rib attaches to the transverse process, which are those two that pop off the back side of the spine. So the ribs have those two joints on the back side, and they are synovial joints, so there are techniques where you can mobilize those joints, mobilize the ribs. You can even manipulate them in certain positions. So we do see in people, a lot of times I'll see people that look like they have rib-related pain, and so working on those joints can be helpful. So just an interesting thing about the thoracic spine is to have the ribs, and obviously the ribs are there to help protect your internal organs. But having the ribs there is more attachments, more joints, so it means that the thoracic spine is naturally a little stiffer than your neck and low back. It's just, you want it to be stable and stiffer because it's protecting all those organs. So structurally, the reason it's stiffer is because of these rib attachments. So flexors, looking at the musculature, they're the same as the lumbar spine, so we're still going to use our abdominals to flex the thoracic spine. Extensors, now we're seeing these muscles continue up, so it's the same muscles. Remember we had iliocostalis lumborum before, but now we have iliocostalis thoracis. Longissimus is a really big muscle. These are the ones you can feel on the people who have well-developed back muscles. You can see them. They run down both sides and they're real thick. They're called the erector spinae. If you put these three together, iliocostalis, longissimus, and spinalis, those three muscles make up the erector spinae group. And because they're in the thoracic spine, they all end with the word thoracis. And then we see this new muscle, semispinalis, which will continue up into the neck, another really important spinal extensor. Lateral flexors, again, some are extensors. If they work on just one side, they'll cause a side bend. So iliocostalis thoracis and longissimus thoracis are primary lateral flexors of the thoracic spine. And then rotation, we have our rotatories. So there's a muscle group called the rotatories, and because they're in the thoracic spine, again, they'll be thoracis. They help to rotate the thoracic spine. There are these smaller muscles that are deeper that help with rotation. And then semispinalis, if it works on just one side, will help create rotation. So some kind of new ones there. Again, a lot of anatomy classes don't cover these in depth until you get to graduate school. So if you're going on to physical therapy school, occupational therapy school, into graduate school, you'll probably dive deeper into these. You may even dissect cadavers and look at them. So good to get a jump start on them now. For ribs, we want to look at some of the kinematics associated with ribs, and ribs are said to have these different movements. So if we look at our upper ribs, these are the ribs up closer to your neck. They are said to have a pump handle motion. And the way you can feel this is if you put one hand on your upper ribs and one hand on the side of your body down on your lower ribs, and you take a deep breath, you'll feel that your upper ribs have more of an anterior-posterior movement like this, which is sort of like a pump handle. Imagine if, I don't know if you've ever camping and you use one of these pump handles to pump water into a bucket. So it's kind of an anterior-posterior movement. Your upper ribs are thought to have that. Down below, you'll feel your hands go out to the side. And that's more of a medial-lateral movement for ribs 7 through 10. And that is said to be like a bucket handle, like a bucket that has the metal handle that flips from side to side. So that's more of a medial lateral movement. So that's how we break those two down. And then the lower ribs have this caliper action where because they're not connected in the front, they kind of open and close when you take a deep breath. And I don't have that written on here, but those basically have, those lower ribs have a caliper action, it's called, where it kind of swings out to the side almost like the picture is showing here. Those two floating ribs, because they don't connect in the front, they would swing out to the side when you take a deep breath. So pump handle at the top, bucket handle in the middle, and then caliper at the bottom. And when we think about breathing, we want to think about ventilatory muscles, another really unique thing in this section. And you'll know a lot of rehab practitioners look at breathing patterns in people, especially when we start talking about neck pain and some of the mid-back type pains. We look at how people are breathing, and some people really use their neck a lot to breathe, and we'd like to train them to maybe do a little more stomach breathing, and really that's initiated and created by the diaphragm. So your diaphragm is this large muscular organ in the lower abdomen that changes pressure in the thoracic cavity, and that creates this inhalation and exhalation that we just do so naturally. But the diaphragm accounts for a big amount of breathing. I think I might have the percentage. Yeah, so diaphragm is 70 to 80% of inspiration action during quiet breathing. So before I jump down there though, also these intercostal muscles, which are the muscles between our ribs, and then the scalenes, which are in the neck, those three are considered primary breathing muscles. Secondary breathing muscles are any muscle that attaches the rib cage to the shoulder girdle, head, or vertebral column. So if a muscle runs from the rib cage to the shoulder, your head, the spine, they can contract and help with breathing. So there's a ton of muscles in there that can do this type of thing. So, as you look through your anatomy, anything that attaches to the ribs, you think about a muscle like pec minor, pec major, they attach to your ribs, so they're technically considered secondary breathing muscles, but there's a bunch of them. So again, though, we're thinking about breathing as being primarily the diaphragm, and what's helpful to think about in terms of what's happening with breathing with the diaphragm is your diaphragm kind of forms a dome. So when you contract your diaphragm, the muscle fibers shorten and the diaphragm becomes shorter. And when that happens, it leaves more volume in the thoracic cage so the lungs can expand, which means pressure drops inside your lungs, which brings air from outside in. So if the pressure in your lungs drops, air from outside, the pressure outside is now greater, so it will force air into your lungs, which creates inspiration or breathing in. Now your diaphragm is squished. If you let your diaphragm relax, it will become taller, which means it will take up more space in the thoracic cavity, which means your lungs get squished a little smaller. That means pressure goes up in the lungs, so pressure increases in the lungs, and that forces air out because now the pressure in the lungs is greater than the outside pressure of the normal atmosphere. So then air comes out and we exhale. So that's how you want to think about it. When your diaphragm contracts, you breathe in. When your diaphragm relaxes, you breathe out. Excuse me. So that gets confusing to a lot of people, but if you can think about kind of an illustration of the diaphragm and its muscle fibers contracting and relaxing, that'll help you think about how this breathing action works. So how about some disorders? So scoliosis, we can see scoliosis in other areas of the spine, but more substantial curves often are seen in the thoracic spine. There are different types of scoliosis. Well, idiopathic here just means that the exact cause isn't known. So that's used with a lot of different disorders. If it's idiopathic, we don't fully understand the cause. There can be genetic cases and congenital. Congenital means you're born with it. So genetic and congenital in a way kind of work together. But you could have genetic disorders that come on later in life, so not necessarily, they don't always go together. Scoliosis is named by the side of convexity. So if you look at this person's thoracic scoliosis, because the convexity is on the right side, we would call that a right thoracic scoliosis. See over here is concave, it looks like a cave. Over here is convex. But then if you look up higher, there's also a scoliotic curve up here in the high thoracic spine up into the neck, so that would be a left upper thoracic, maybe even cervical scoliosis. And then again down here in the lower thoracic into the lumbar, we see another left scoliotic curve. So we have a left, then a right, and then a left, all named by the side that's convex. And these can be broken down in different categories. So we can have structural scoliotic curves where the bone is actually deformed. Usually in those cases, if it's really severe, we look at, physicians will measure the Cobb angle. And if the scoliotic curve is large enough that it interferes with breathing, then the person may undergo surgery to help straighten things out. If it's a bony deformity, rehab's not going to do much to it. And then non-structural or functional scoliotic curves can be associated with postural issues, maybe habitual postural positions, muscle spasm. You can imagine if you had a muscle spasm, say on this lower left lumbar scoliosis, maybe if there was a muscle over here like quadratus lumborum was spasming, maybe it would pull this side of the spine and create this concavity. So you could have an issue like that. A leg length discrepancy, if one person has one leg that's much longer or shorter than the other, that could affect the curve of their spine and create a functional scoliosis. So those are things to look for if you see one in somebody and it looks like it's maybe more of a non-structural functional issue. Maybe there are things you can help them with. So these functional scoliotic curves, again, rehab, exercise, we can play a part in helping people. Compression fractures, these can happen throughout the spine too, but you tend to hear about them more in the thoracic spine. This is where you might see an older individual who has osteoporosis, where the bone density is less, and it basically is a situation where there's this compressive load and the bone breaks. There are procedures where surgeons can come in here and inject cement. They can put a balloon in here and lift the vertebrae back to its normal position and then fill the cavity with cement. It's called in the thoracic spine, it's called a kyphoplasty. So surgeons can correct this in some cases. So compression fractures are a pathology we hear about in the thoracic spine. Okay, and then the neck. I know this is kind of gross to some people, but I thought this was such a cool, this is a picture I took, a dissection, or somebody, the head was removed and then cut in this left and right, into left and right halves. So you can see the neck here, just kind of a neat dissection to see the cervical vertebral bodies and then some of the bony elements of the back side of the spine, and then how the spinal cord would run through here. So pretty cool. Okay, here's just a nice video, functional MRI looking at movement of the cervical spine. I've shared this on my Instagram before, so you may have seen it. But just kind of a really neat one to see movement in real time in the neck. And this person is primarily doing upper cervical movement. They're kind of nodding their spine. You don't see a lot of movement down in the lower cervical spine. So this would be like you're just lifting your chin up and down, like you're saying yes to somebody. But a pretty neat real-time visual of the neck in action. I mean, there's lots of things to look at here, but you're just looking at the neck. Okay, and then ligaments, really important ligaments in the neck. These are things that if somebody's in a really bad car accident, these are things we like to make sure aren't damaged, because if they are, then the head can move around on the spine and they're at a much greater risk of having an injury to their spinal cord. So one of the ligaments is the apical ligament. This runs from the dens, which the dens is a piece of bone that comes off so you have your skull, then the C1 vertebrae, and then C2. The C2 vertebrae has a bony element that comes off called the dens, and that hooks up into the C1 vertebrae to create rotation. But there's a ligament called the apical ligament that goes from the dens of that C2 vertebrae up to the backside of the skull. So it basically attaches one of your upper neck vertebrae to your skull, so you can imagine how important it is. If you tear that, now your skull's not attached to your spine as well, so big problem. So the fibers have kind of a vertical alignment. Then there's one called the alar ligament that goes from the dens to the occiput at more of an oblique angle. So again, attaches that bony dens from the C2 vertebrae up to the back of the skull. And then the transverse ligament is an interesting one because it goes from the atlas. So it is at your atlas bone is the same as C1. So it's the very first vertebrae in your neck. So your skull, and then there's the atlas. So your atlas is holding up your skull, and this ligament, this transverse ligament, holds the dens. So that dens bone again from over here is coming up off of C2, the next vertebrae down, and hooking into the atlas into C1. The transverse ligament holds it in place. So I know it's a little hard to understand without a picture, but just all that to know that these three ligaments basically hold your skull on your neck. So somebody's in a bad whiplash accident or something, a really traumatic sporting injury where their neck is injured, these need to be looked at and ruled out because if one of them is torn, it can really increase someone's risk of a spinal cord injury. Okay. Muscles, tons of muscles in the neck. I'm not going to cover them all here, but some of the important ones here for flexors, we have rectus capitis anterior. We have the scalene muscles I mentioned before that help with breathing. You can see them right here in the picture, anterior, middle, posterior scalene muscles. These two, longus coeli and longus capitis, are important stabilizers of the neck. We train these sometimes with different exercises. There's one called the deep neck flexor hold that we use to train those, and some people with neck pain. Extensors, we have, again, on the backside, the name changes, but here's that semispinalis muscle we saw before, but because it's in the neck now, we call it cervicis. So these are all on the backside of the neck. Spinalis, cervicis, spinalis was down in the thoracic spine, and then this new muscle, splenius, because, again, the neck, so splenius cervis. So those extensors. Rotators, on the front side of your neck, you have your big sternocleidomastoid. Sometimes it's abbreviated as SCM. If that contracts just on one side, it will cause your head to rotate to the opposite side. Your scalenes that we saw here also help with rotation. So this is not all the muscles, but just to give you an example of some of them that are involved in movement. I'd also think of your upper trapezius muscle, that one where people get a lot of trigger points. That one's going to help with side bending the head and rotation. So extension. There's a ton of muscles in this region. In terms of nerve roots, the neck is kind of interesting because there's actually 8 nerve roots but 7 vertebrae. So that's something, an important distinction. There's a nerve root that comes out. The nerve root comes where it comes out underneath, and that's how it's named. So the first C1 nerve root comes out underneath your skull. So you can see it right here. So here's C1, here's the skull. Here's the first vertebrae, that's the one that's called the atlas. So C1 comes out underneath the skull. C2 then comes out from underneath C1. So if you count like that, work all the way down, there is a C8 nerve root that comes out underneath the C7 vertebrae. So right, and there would be one on each side. Same thing on each side, and these are the nerves that go down and give us sensation and motor into our arm, especially from C5 down. C4, these upper ones will help with the neck muscles, and then these lower ones will start going down in the arm. For instance, C5 is thought to mostly kind of be associated with helping with moving the deltoid, C6 with the elbow flexors, your biceps and things, C7 with the triceps. So that's where they'll be primary motor segments for. And these nerve roots, compared to the other regions of the spine, there's not a lot of room for them. The neck is very compact, and so things like if you have a disc herniation or arthritis in the neck, it can often bother these nerve roots because there's just not much room. The facet joints are much smaller. The intervertebral foramen where the nerve comes out is much tighter. So we see, this area is a little more prone to some of these injuries because of how compact everything is. Looking at, just some of the movements in the neck, in the upper cervical spine, I have this broken down. There's just really 2 joints we're going to think about. O stands for occiput, so that's your skull. So your skull on top of C1, that is mostly involved in flexion extension, so sort of nodding your head up and down like we saw in that MRI. C1, C2 is the first and second vertebrae, your atlas and your axis, coming together, and that's that pivot joint where we see more than half. Remember there was that joint in the neck that gave a ton of rotation, so that is this one. And then down below the lower cervical spine, we see all of the segments contributing to movement, but I wanted to point this one out, like in the low back. Most of our flexion extension comes from C5, C6, but we also see it in the adjacent segments of C4, 5, and C6, 7, but most degeneration in the neck is at C5, 6, which again, it fits with the lumbar spine. You see a ton of movement there, so you're probably going to see a little more wear and tear. Sorry, I don't like to use that wear and tear phrase, but so if you move somewhere a little more, it's probably more likely to kind of show some age-related changes. So keep that in mind for both the low back and the neck. And then just some quick pathology here. Again, disc herniations and spinal stenosis we talked about in the lumbar spine. Those also are quite common in the neck, and disc herniations, like the low back, they can heal. If they don't heal and the person has pain for long periods, or their muscles, they start to show muscle weakness, then surgeons can go in there and do a microdiscectomy and trim out the area of the disc that's interfering with function. Spinal stenosis is just that narrowing of the hole where the nerves come out. Whiplash injuries are a really interesting one in the neck because some people go on to have chronic neck pain after whiplash injuries, so it's a kind of a neat area of study if you're interested in studying the neck more. So just a short list of some of the pathologies in the neck. By no means is this all of them. There's other things that can happen, but I just wanted to point some out there. So that is the spine in a very quick, 30 minutes or so. So I hope this was helpful to you. Please, I'll put this up on YouTube. Feel free to comment and let me know if you have any questions. All right. Talk to you later. Bye.